Okay, 10:01. We have almost 200 people signed up, so we'll get started. So welcome. You have signed into the webinar called Best Practices for Co-occurring Disorders Treatment. Today's webinar in particular is about integrated treatment planning, service provision, and continuity of care. This five-part series is hosted by the Great Lakes, Northeast and Caribbean and Northwest Addiction Technology Transfer Center and the Great Lake Mental Health Transfer Center. This is the fifth and the final of this series, following last month's presentation, which was intake, screening, and assessment. My name is David Jefferson. I'm the Director of Training and Technical Assistance from the Northwest ATTC, and I'll be your host today. So a couple things, a little bit of business. The chat box is, everybody to communicate with each other, share your thoughts as we go along. If people have a question in particular, I'll ask you to go over to the question and answer box and put that in there. We have a pretty busy day ahead of us, and we'll be able to take a couple of questions as we go along, and we'll also take some questions towards the end of the presentation. So with that, I'd like to introduce you to the Technology Transfer Centers. We both have Addiction Technology Transfer Centers and the Mental Health Transfer Centers. There's 10 across the region in the United States. These are funded by the Substance Abuse and Mental Health Services Administration. And there's also prevention transfer centers. And so these are very rich sources of information. These are at your fingertips, and hope folks out there make good use of these. Everybody that is here today, you will get a certificate of attendance. You don't need to do anything. That'll come to you automatically in about a week. However, if you're with a group of people, send us an email to that address that you see on your screen. I'll also put that in the chat box so it's easy for you. And give us the name and the email addresses of the people that you're with in that group. And we'll make sure that those certificates go out to folks. And let's see, with that, we're also going to send you folks an evaluation at the end of today's training. And it takes a few minutes. We'll put that in the chat box, but we'll also send that with follow-up email, so folks will be able to get that also. So let me introduce our presenters today. We're very excited to have the folks here presenting. First, I'd like to introduce Mike Chappell. He is the director of the Northeast and Caribbean ATTC. He's also assistant professor of clinical psychiatry at the New York Psychiatric Institute's Division on Substance Use Disorders at Columbia University Medical Center. Welcome, Michael. Next, we have Dina Vandersloot, who's the co-director of the Northwest ATTC. She has been providing DDCAT assessments and coachings to providers in Washington for over 10 years now, and an amazing trainer in motivational interviewing, integrated treatment, expert, and NIATEX process improvement. Welcome, Dina. And we have our guest today, Matthew Fox, who's the program supervisor of the Whole Health Institute at Integrated Services of Kalamazoo, Michigan. For the past 20 years, he's assisted people with mental illness and substance abuse issues to develop pathways to recovery and empower them to succeed. Welcome, Matthew. Glad you're all here. And with that, I'll turn it over to Michael, and there you go.
All right, hello. Can everyone hear me, David?
Yeah, I hear you.
All right, when you switch the thing, the mute button relocates itself. So you got me there.
Okay.
Thank you, everyone, for participating and for having me. Again, like David said, my name is Mike Chappell. I am an assistant professor of clinical psychiatry at Columbia University. And like Dean, I have a lot of experience using the DDCAT tool. And for those of you who haven't been with us prior to today's announcement, we've been sort of using this tool as a conceptual framework for thinking about how to best integrate services for mental health and substance use disorders under our licenses and our structures and whatnot. And so we've been systematically working through the dimensions of the DDCAT, which are outlined on the current slide. And what we did was we started with program structure and program milieu, which is really getting at what is the licensing and billing and all the structural elements of the program, as well as the cultural elements of the program in terms of receptivity, as really a starting foundation for thinking about integrated care. Moving to staffing and training, these are the kind of tools that need to be in place. What you can do and can't do really depends in large part on the kind of staff you have in place. And what staff you have in place will often inform capacity building efforts and what kind of training and technical assistance you might request. And from there, we moved on to assessment, which really was a focus on intake, screening, and assessment procedures, right? That's the front end of the clinical continuum. And now we're sort of moving through that process, and we're going to talk about treatment planning, treatment provision, and then discharge planning, which is continuity of care, and in a nutshell, as sort of carrying through on that continuum. So I just want everyone to understand that progress there. The agenda is fairly simple. We're going to review the constructs of these tools, the DDCAT and DDCMHT, that really, again, set a framework for understanding what are the critical components or the critical goals and objectives around integrated care. In doing that, we'll review some of the recommended strategies and the things that you need to be thinking about as providers. We will also bring in Matthew, who is a provider himself and has experience with these integrated care challenges, to sort of illustrate how he's addressed some of the things we've been talking about in service. And at the end, then we hope to have some time to address some questions that you may have. So we have a lot of goals listed here. Just want to outline really briefly and quickly kind of what we're going to cover today. And, obviously the notion of treatment planning and treatment provision covers a lot of potential contingencies. So we're looking at the act of actual treatment planning and looking at how both disorders are addressed in the process of doing that, how ongoing monitoring is done for the course of these disorders and the interaction between, in thinking about procedures for emergencies and crisis management, both in terms of mental health and substance use, procedures for medication evaluation and management, and then elements of treatment, which have different components like stage-wise treatment, psychoeducation, specialized services like evidence-based practices. How do we include the family, and how do we include peers? And so that's a lot to cover, and we're going to do our best to do that. I wanted to bring this graphic back to mind as a way to think about the notion of integration across this clinical continuum, which we started talking about during our last presentation around screening and assessment. And I would liken it to the HIV cascade of care, or what's come out as the opioid use disorders cascade of care, which is adopted from that, or for substance use disorders more broadly. And it's sort of that goal of 90-90-90 that some of you may be familiar with. And looking at, when we go out, we want to assure that we're screening, that we're doing high levels of screening to be able to identify the disorder. And that for everyone who gets screened positive, we're doing extremely high levels of assessment for most of the people who screen positive. And for people who we diagnose a substance use or mental health disorder, that when we're doing treatment planning, we're addressing those disorders, both disorders and treatment planning for the large, it really should be 100%, but the 90-90-90 is based on the recognition that nobody's perfect and there are service challenges and limitations. And so it's being addressed in treatment planning, and then being addressed when we treatment plan, is the treatment actually being provided? And is it being addressed in discharge? So you really can think about it. I think about it as like pulling a common thread through this. Are we identifying everyone we need to identify? Are we diagnosing everyone who we identified? Are we planning appropriately for everyone we diagnosed? Are we providing treatment for everyone we planned for? And are we discharging for everyone we treated? So it's really making sure we keep that high expectation that people aren't falling out of the cracks, so that by the time we get to the end, people are getting very little in the way, for example, in terms of discharge planning. So just something conceptually to think about. At this point, we're gonna launch a participant poll, really to look at just what are some of your perspectives as to what is being done in your program around some of the key aspects. We're not touching on all of them. We just picked a few, but looking at some of the key aspects of integrated care as it pertains to treatment planning and provision. So, for example, the poll is launched, people are responding to it. Our treatment plans routinely reflect goals for both disorders. So if you're in substance use disorder treatment and you know someone's been identified with a mental health disorder, is that being addressed in treatment planning actively, routinely, normally? Is that the norm? Clinician progress notes routinely reflect a focus on both disorders. So does it continue as clinicians meet with their clients, their patients about their progress in treatment, what they're doing, the groups, the individual counseling they're receiving? Is there a continuous focus on both disorders and how that's playing out in treatment? And then when it comes to the actual treatment that you can provide, and this is where, we often get stuck, right? I mean, one of the reasons why a lot of programs are hesitant to screen in the first place is because they don't know what services they can provide for the people once they identify them. But that can be addressed based on the reality of what staff you have, and it can come in many different forms. So the idea, again, around integration is to identify realistic goals for your programs based on your resources, including staff. So are there opportunities to offer either, basic psychoeducation or specialized treatment interventions, what we often refer to as evidence-based practices for the treatment of both disorders or the other disorder? And that's what those questions are getting at. So we have, I think you've closed the poll, David.
Meg would have done
Yes,
that.
yes.
There you go. Sorry, I got my roles all mixed up.
Okay, people stopped responding, so I think it's good.
Thank you, Meg. So looking at it real quickly, our treatment plans routinely reflect goals for both disorders. About almost 3/4 said yes, that's the case. Clinician progress notes routinely reflect a focus on both disorders, and that's at about half. And our program cannot offer either psychoeducation or specialized treatment interventions, again, at about half. So, I think that's probably what I would expect, or at least in my experience in terms of administering the DDCAT and DDCMHT, and I think these are things, regardless of what you may think, what your impression may be of what's going on in your program. If you're in a supervisory or leadership role, these are things that you can think about looking at from a quality improvement perspective. How is this being done across the providers that you have? Because we always know if there's anything, when we sum it up, it may be one thing, but when we look at variability across providers, it may be another thing. And I think this reflects sort of the variability that this is and is not occurring. And we're hoping that some of the focus that we bring in today's presentation and some of the recommendations will help programs to think about some of the first steps they can take towards, improving these outcomes. Okay. So first thing we're going to do is we're going to look at treatment planning. These bullets are going to fly in, so I'm just going to, Treatment planning. So first step in the process when you've identified someone, when you've diagnosed someone through assessment with a substance use or mental health disorder, is filling out a treatment plan. And so I think that there is, it may seem like a really intuitive thing to do, but the goal is that we're setting the stage with treatment planning that both mental health and substance use disorders will be addressed throughout the course of treatment. And so that ultimately it'll be formally documented as part of the treatment plan and the progress notes. And you can look to see by reviewing some of the work that's being done by clinicians at the program, the extent to what that's happening. And so the focus on co-occurring disorders should be routine, not variable across clinicians. It should be part of policy in terms of informing how that's to go forward. Focus on both disorders should be equivalent to the extent possible. We realize, I know I can say from from New York State, where we have two separate service systems that oversee mental health and substance use, that if you're receiving services in either system, that there has to be a primary disorder in that system of care. So if you're getting substance use disorders treatment in an Oasis licensed clinic in New York State, substance use has to be the primary disorder. So I understand that there may be licensing limitations to that, but the idea is that, you know, there should be relatively equal focus paid to those disorders. I think most importantly, I would say, so these aren't necessarily in the order of importance, is, are we establishing specific goals and objectives for both disorders and that address the interaction of both disorders? So, I mean, this is about treatment of the whole person. It's really, we've been, you know, largely forced into thinking about these in silos, but the reality is that's not how it is for the individual in treatment. And so not only should we at the very least have separate goals and objectives established for mental health and substance use, but we really ideally would think about looking at the interaction between those two disorders and how we're going to address that in treatment. And then thinking about what specific interventions can we bring into play regarding treatment plan for both disorders. And that includes psychoeducation, psychosocial evidence-based practices, pharmacological treatments, so on and so forth. And that is going to depend on building capacity to deliver those interventions. And then we also want to think in terms of treatment planning, exploring beyond behavioral health, mental health, or substance abuse. And so thinking about building treatment goals around all aspects of the client's life that could facilitate or impede treatment engagement, retention, longer-term outcomes. I think the one thing I've seen so commonly when it comes to treatment planning, and we've done a lot of training just specifically on best practices around treatment planning, is that goals are overwhelmingly focused on abstinence, or getting to abstinence around substance use, for example, or, you know, other forms of, you know, stability around mental health disorders, symptomatology, and things like that. And that the reality is that most clients or patients can't do that without having other aspects of their own stability addressed, and, you know, having to do with what is the role of the family background. So family treatment, we'll talk about that a little bit later, but, you know, sometimes they're an asset and sometimes the family is part of the challenge. Employment, religious, spiritual involvement, physical functioning, health conditions, and all the things you see, legal concerns, right? If there's justice involved, there's a tremendous amount of need for collaboration to make sure that you're speaking the same language across systems and that each understands competing priorities and demands. Other environmental factors, client strengths, et cetera. There's a lot more to the client than their mental health and substance use disorder. And we all know that. And a lot of this seems like a very tall order in terms of how much is realistic for us to take on. But a lot of times, I mean, this is a very central tenet of motivational interviewing. You meet the client where they're at and you think about what's going to motivate them. And so, you know, just addressing substance use or mental health straight on may not be the way to go. There may be other ways in. So assessing and monitoring the course of both disorders, you know, this is as treatment is being provided and as clinicians are checking in with clients, that they're continuing to carry that dual focus through. It wasn't just a goal put in the treatment plan, and then we sort of revert back to focusing on what we're comfortable with or what our organization does best. We're looking at, is it routine? And the one thing we have is a progress notes. Oftentimes we can look at, supervisors can look at progress notes. Is it looking at documentation of such in the progress notes where there's a reflection of progress on both disorders, on the interaction of both disorders, where it's fairly consistent across clinicians, it's equivalent to the extent possible. All of those different things we can build upon to ensure that there's that focus happening in progress notes. Again, think of the dominoes. We may accomplish our treatment planning goals, and then we may really revert in terms of our focus in ongoing monitoring and assessment. So also have to think about procedures for crisis management. This is one of the things, putting in place specific clinical guidelines to manage mental health crises and emergencies for mental health programs, for really for substance use disorders programs, I should say. This is slightly reversed, my apologies. And for mental health programs to put in space specific clinical guidelines to manage substance-related emergencies. So this has a lot to do with, the kind of clients we can treat. And if these procedures are in place, I often hear when we work with substance use programs is that, they're only able to work with clients with certain types of diagnoses or that exhibit certain types of disorders. And when you work with mental health programs, you often talk about, well, we really can't work with people who have active substance use disorders. We want them to be in remission, long-term recovery. We don't know what to do if they're high or they're intoxicated or other sorts of things. And having those procedures in place allows programs to be a lot more confident in their ability to manage these types of clients when those issues arise. And so it's better to have those written procedures because unwritten procedures get interpreted very conveniently by clinicians. A lot of times it's unwritten procedures, and then when you ask across providers, you get very different interpretations of what the actual expectation is. And that includes, having things in place, around, those documented protocols. And not just being called 911 or something really simple like that, having very specific protocols in place. And so, having staff know what those are and being able to follow those guidelines. And that's a very important piece to increasing self-efficacy around dealing with clients with co-occurring disorders. Medication monitoring, goes both ways. Again, the capacity to prescribe and monitor medications, whether we're talking about psychotropics for mental health disorders or FDA-approved pharmacology for substance use disorders. I mean, the issue really is some clients may come with already on these medications, and we don't want that necessarily to be some kind of criteria that precludes their participation. And some clients may need to be engaged and put on those medications and to think about what is our capacity for doing this. So at the very least, can we evaluate medication needs? Can we facilitate access to medication when needed if they don't already have access? Can we monitor clients on these medications if they're on these medications, whether you've prescribed them or not through your program? Documented plan for managing that is helpful, as I just said. And then ability to respond in-house to difficulties or at least get that kind of consultation. So again, different layers of this. You may not achieve the ideal. So in mental health settings, this also means, when we're talking about MAT, medication-assisted treatment, medications for opioid use disorders, we're talking about what is the knowledge and ability to facilitate attention to medications to treat intoxication states, right? We're talking about management of medication withdrawal symptoms, policies about the use of benzodiazepines and other potentially addictive medications, and that sort of thing. So I want to, in the interest of time, I want to kind of stop here and give Matthew an opportunity to talk a little bit or illustrate a little bit of what he's been doing or what he's encountered regarding all these things I'm addressing around treatment planning, provision, focusing on both disorders, how that's been accomplished, and some of the challenges I think primarily of most people are thinking out around medication monitoring and provision and management. So Matthew, floor is yours.
Matthew, I think you're still muted. You're on mute. We know you're saying great stuff, but we can't hear it yet.
There we go. Okay, so in terms of when you're talking about assessments and treatment planning, there's so many different facets of someone's life that we are trying to get information from them in order to build a service, build a treatment to help the client. And so a lot of times for me, the assessment is I'll ask pretty much 3 different questions. First of all, what is preventing you from being successful? So I think sometimes starting that off with a client, you're able to get today, what are they struggling with? In terms of when we're looking at historically, what are some of the pieces in terms of their mental health, substance use, their physical health, I'll ask, at what point in your life did you realize something was wrong? And then basically kind of the last question I ask is what do you need to succeed? So I think having those open-ended questions, those 3 questions, you're going to get a lot of information from, the person that you're meeting with, and we might ask a couple questions in terms of clarification. And so when we're developing this assessment, then we're identifying what are those needs that the client is, struggling with, and developing that treatment plan, which is encompassing, and I like how you kind of talked about the holistic approach. 2 pieces is that mind, body, spirit. And so if we're looking at, what are some mental health disorders a person is struggling with, what are some of the physical health barriers in terms of, we all know that diabetes, hypertension, people in pain, a lot of those symptoms can be looked at as mental health symptoms in terms of depression, which in terms leads, people to seeking relief, which leads to sometimes that substance abuse piece that we're identifying. And then from there is involving the client as part of the treatment team. We are fortunate in our program to be able to have the psychiatrist in these meetings, their primary care physician in these meetings, their case managers, their therapist, the peer supports, which to me, peers are the greatest thing that has ever happened to our profession in terms of being able to relate to those different clients in developing these treatment plans. And most importantly is that discharge summary is what does it look like when you are ready, that you have reached, this independence to be able to manage these things on their own.
Okay, thank you, Matthew. I'm going to cover what feels like a lot of information in the next 15 minutes or so. Hold on just a second here, if I can get it to.
So, Dina, while you're doing that,
yeah,
let me just pose one question to Michael that came through, and people
sure.
wanted to know when they work in an agency that has chemical dependency counselors and mental health counselors, should they be working off of one treatment plan?
That would be ideal. I know in New York State, we don't have the ability to do that because we have separate service systems. So what we end up, and they're talking about merging them right now. And even when they get merged, as many other states probably are aware of here, it's not always smooth. It can take 10 years to figure out what that is actually going to look like. But we don't have the ability to really have single treatment plans because you'd actually have to share information, across licensed providers. And so, if you have dual licenses that are under one roof and you don't have those kinds of barriers, a single treatment plan would be ideal. I don't know, Matthew, if you as a provider have more practical advice in terms of how realistic or achievable that actually may be.
I think generally someone coming into services, they generally would have a prime service that they have in terms of a case management, which then in coordination works with, if they're receiving substance abuse treatment from another agency or their primary care, what other services. I think addending their original plan to coordinate or to incorporate all this coordination, I think when you have too many hands in the pot, but no one is kind of communicating, having that central treatment plan is helpful. And if we're having that coordination, if we're sending our treatment plan to another provider that's providing another service, again, we don't want a duplication of services and we all want to be on the same page. Do I think it's possible? Yes. Do people think it's kind of time consuming? Also, but what are we trying to achieve is the best outcome for our clients.
Thank you. Dina, over to you.
Thanks. So we're really going to delve into what treatment interventions, what are the treatment interventions that are most effective for individuals with co-occurring disorders. And there isn't one single treatment intervention or evidence-based practice. And that I think is where, throughout the last, decade, there is really this idea, or a couple of decades of stage match treatment, or sometimes you hear it as stage-wise treatment, which Matthew talked about and Mike as well. It's really that concept that you're meeting people where they are at. And on an ongoing basis, really assessing like their readiness for change with all these multiple areas, mental health, substance use disorder, employment, multiple areas, and then matching up the actual intervention to the stage of change that a person is in. And sometimes that's treatment content, sometimes it's the intensity of the services, or referral to other agencies. So where do you start with something like this? Well, of course, and this once again, and there's this common theme throughout this, that if you can build it into your documentation, you really have then a way to assess and monitor, and it's almost as a prompt for clinicians, like, okay, now it's time to look at 60 days or 90 days. Where is the person in these multiple areas? And how is the treatment plan really reflecting that? So, if you have somebody, say you have somebody with bipolar disorder, and they also have a stimulant use disorder and an alcohol use disorder, you're looking at all those different disorders and identifying where is a person. And if maybe with a substance use disorder, the person is, really in that contemplation or pre-contemplation stage of change, you don't want to be matching them up with a relapse prevention group. I remember listening to an audio session of somebody demonstrating motivational interviewing, and this person hadn't really even accepted that they had a substance use disorder, and she was indicating like, okay, let's work on your relapse prevention plan. Well, the person wasn't there, or vice versa. You might have somebody coming back into treatment and they've had treatment and they're in relapse. You don't want to put them in an awareness building group or an education group. So really trying to match as best that you can. Now, it's hard because you can't have necessarily, I'm sure Matthew can attest to, 20 different groups for people. Yeah. And I think this goes where if it is really in the treatment plan, the groups people are using or individual sessions, can the interventions be tailored? So just to
and I think, if I can interject,
yeah, sure.
I think one of the difficult parts in some of the agencies and programs I've worked at is when we have referrals from the treatment courts in terms of like drug court, sobriety court, CPS, and people are on probation, is the referrals are like, they need intensive outpatients, and if the person is in pre-contemplation, it's not going to go over very well. But and so some of the barriers is that time limited, the pressure from, these other agencies, which I think a lot of times set people up for failure.
Yeah, thanks, Matthew, because it really is. I mean, I think there's lots of barriers to actually doing this. And so, you, to the degree that you can actually match, and this is, I'm not going to go into this slide in depth at all, but this idea that if you can match the stage of change with the stage of treatment, and then the interventions, or, even the intensity of treatment when possible. You don't really want somebody in residential treatment that may have no level of readiness, and really where you might prepare them better. So just keeping this in mind throughout the course of treatment. There's also this piece of psychoeducation. I think addiction providers have done a really good job for years with this, about really educating clients when they come in about substance use disorders. And so the key here with COD is, are you doing that equally around mental health disorders? Are you going over the signs and symptoms? Are you talking about what medications might be possible? What types of medications are there? And you don't have to go in depth and stay within, of course you want to stay within your scope of practice, but what are the options? What for different disorders? There is a Bill Miller video demonstration out there, and he does just like this magnificent job of a client who has depression, really going over what are the different types of treatments and interventions that work, and where might that person, like what might they be interested in. The other piece, of course, and Mike talked about this, is the interactive course of both disorders. Do people really understand that oftentimes, individuals might use alcohol because they have high anxiety, but do they understand the rebound effect and that the next morning that might be even higher? So really teaching some of that. The idea, once again, is that it's offered routinely, not just by clinicians. I think this happens a lot, just clinicians offer it to individuals, but that it's offered in group or on a regular basis so that people are exposed to that information over time. I have here, and this is really just some resources, many free resources where you can download pamphlets, fact sheets about the interaction between various disorders. So these slides will get uploaded here in a few days along with the presentation. So a chance to take a look. And also I encourage people in the chat box. I know in previous sessions, people have written in some of the manuals or resources that they found to be really helpful. The next piece then is looking at specialized treatment services or EBPs. And this could be a really long list. But what you're wanting to look at is very specialized interventions. And you might look at, if you're a mental health program, you might look at, do you have a relapse prevention group for individuals who have substance use disorder? How is motivational interviewing or CBT or 12-step facilitation? I mean, the list is very long, but are you integrating some of those? I worked with one program that was more primary mental health, but they took the matrix model of treatment, the relapse prevention group, and really customized it so that it fit for their population. If you're more a primary substance use disorder treatment, do you have some special mental health interventions available? I know a lot of programs do seeking safety, and for those individuals who have trauma and substance use disorder. A lot of these other ones here listed, and this is where it's tricky. It depends on the intensity. It's like assertive community treatment for individuals, that is really geared a multidisciplinary approach for individuals that might be higher on the mental health disorder. And so determining which of these really fit with your population, which goes back to, as you collect data and you know what your population is, which of these makes sense. And then you get into very specialized interventions that really look at the dual diagnosis or the co-occurring disorders. Some examples here, DBT, there's a specific one around substance use, double trouble in recovery. So these are ones that look very closely at simultaneously are really addressing both disorders or the multiple disorders a person might be experiencing. So it's a long list. It's really determining which ones will fit for your organization. And once again, have like a list here. Many of these are actually free. There's some of these that aren't, but the majority of these are available free. I think there was a question about what does TREM stand for. It's Trauma Recovery and Empowerment Model. It's one for women who have a history of physical or sexual abuse. So many different evidence-based practices out there. And you probably, in the chat box, there might be many more. So then we look at family education and support. We know people do much better if there's family involvement. And at the same time, I don't know if this is true for you, Mike, what you found is oftentimes this is the area that is not implemented in a lot of programs. And I think that has to do with funding, but I think it's also just clients don't really want their families involved, and clinicians are kind of intimidated by working with families, and oftentimes it's not getting paid. So there's lots of different barriers around this. But, if you look back at Alan Marlett's work around, like what is the #1 relapse trigger for people, it's usually negative emotions. And those negative emotions are usually related to relationships. So this is such an important part. And so, in its education and its support, I think many programs might do this individually, but do they actually have an education group And, how do you define family? Is that, it doesn't necessarily, it could be family of choice. It could be who are the people in the person's social environment that are really important to their recovery. And sometimes it's like, well, they may not be that healthy, but I remember years ago when I was working in a program that we did like a family week. And many of those individuals came in and they oftentimes ended up getting in treatment just due to their involvement in a family education group. So it's really about what are the signs and symptoms and of both disorders. Once again, like what are the signs and symptoms of SUD and mental health? What can you expect around treatment and recovery? And it's really, I think, in more than anything, helping to create a sense of hope in families and sense that, yes, there is a struggle and there are challenges, but there is hope. And also just to understand the interactive force between the disorders. So, I think in today's environment, I know COVID has really wreaked havoc with this for many programs, but virtual almost opens it up in more opportunities. So here are, once again, some resources for people around this, and many of these are free. And then we come to continuity of care. And it is this idea that how do we help move people seamlessly and address both their mental health and SUD issues. And so when you're looking at discharge planning, is there an equal focus on both disorders or multiple disorders? How are you helping people transition? One thing that I often think about is that we know many of the clients have attachment disorders, and so they get very connected with their primary care counselor, and then that ends. And so are there some ways to actually have some continuity of care? One way some programs have done it is with recovery checkups. So maybe quarterly checkups with actually with their primary care counselor or somebody in the treatment facility, so that there's some ongoing care around monitoring. And this all, this is kind of a dimension in and of itself that we look at multiple levels. But it really is, how are you providing continued support for individuals and how well are they transitioning? Which really then gets into, and we've talked about this several times, but do you have some of these peer support where they really can become the bridge? It's a peer support specialist who can really help them integrate into the community, into mutual support groups. So this one is kind of a big area in and of itself, but really using them in multiple ways to make this bridge and continue on. Because we know people, it takes, at least with substance use disorder, at least 5 years for relapse rates to decrease significantly. And so how can we use this to actually continue care into the community? And with that, I'm going to pause and have Matthew talk a bit about that, some of these areas.
Okay. So feedback. So when we're doing assessing the substance part of our assessments, I think a lot of times we're good at identifying what is their substance of choice, how long they've been using, what have they been using. But I think one of the key pieces that we miss is what is the purpose behind the behavior. And so I think so many times we're trying to address the substance abuse part that we're forgetting about what exactly is those underlying factors. And I was reading a couple of the comments or, some of the questions in terms of like using the ASAM. I mean, to me, the ASAM, having those 6 dimensions and really outlining in these 6 dimensions, how do these impact someone's overall recovery? And so depending on what my agency is, so if I'm working just in a substance abuse agency, or if I'm working in a mental health agency, or if I'm doing co-occurring treatment work, am I addressing, how does trauma come into play? How does my physical health come into play? And so if I'm asking, and in my groups, I've asked this a lot of times with people is can you define sobriety? And a lot of people cannot define what sobriety is. And the same thing as this, like, what's the importance of medications? To me, sobriety and medications only do one piece. They get us to a point where we can start thinking clear, and then we can start looking at all these other dimensions that have an impact on our overall recovery, and be able to, with these different dimensions, be able to have that continuing method of care for discharge, that if I could work on my sobriety, then my next step would be going to therapy, using DBT, using seeking safety to help me through some of the trauma and some of those other barriers. Having that discharge planning of connecting with my primary care physician to develop a recovery plan that addresses my medical health. And so there's all these different facets that, you know, we need to be able to address, so this person is able to develop that plan, have those family supports, having those peer supports, so they can be successful.
Right. Yeah, it's almost within that context, and all of that held within the context of the therapeutic relationship, right, Matthew?
Correct.
I think that's what I heard you start off for that. You know, I think we're going to switch over to take some additional questions. Just want to say, kind of as wrapping up this part of it, is David and I have actually, our moderator has actually, we just completed a review of 10 programs using the DDCAT. And the one thing that, you know, we take away is that, you know, as you've listened to today's webinar and previous webinars, there are a lot of different dimensions to co-occurring disorder. And one thing that we've really recognized is that many providers are out there doing a lot with very little funding and getting compensated for that. So it really speaks to the quality of care out there and people really being dedicated to doing this work, because there are multiple dimensions to it. So just want to acknowledge that. David, do you want anything else, Mike or Matthew, before we move on to taking some questions?
I was going to say, Michael, that when Dina was talking about families and peers, I'm wondering, what have you seen with providers taking care of families and peers on the East Coast over there?
I mean, I would say it would be a contest between those two dimensions on which one is more of a struggle. As Dina sort of said, in terms of family support, it's a recommended evidence-based practice, but it's rarely done because there are a lot of barriers. With peer integration, it's the same thing. But I think when I was doing DDCATs and DDCMHTs, I think the landscape for peers was a lot different. And I wasn't doing them a long time ago. I mean, maybe 6-7 years ago, where I was actively involved doing these assessments, and we still do them from time to time. But I know, for example, in New York State, we've since had a certified recovery peer advocates certification in. The role of peers is becoming more professionalized. There's increased recognition of the value added by peers in terms of everything, from just the ability to engage and help engage clients to, you know, that peers aren't just caddies for doing all the stuff that everyone else doesn't want to do, and they have a lot to contribute to the landscape, but there are still struggles around their integration. What are the appropriate roles and responsibilities? How do you supervise those peers? What do you do around wellness and relapse prevention, and other sorts of challenges? You know, one of the major struggles is a lot of the effort that goes to onboarding peers in agencies that are highly bureaucratic, and then there's a relapse or something like that, and they have to start all over in their investment. There's a lack of, you know, there's somewhat a lack of understanding and respect among professionals about the role of peers. There's sort of like a little bit of a culture clash, if you will. And so there are a lot of challenges, but I think the landscape for peers is emerging, at least in New York State. I'm sure that's true in other states, and I'm sure there are states that are ahead of New York in that regard. I think we're kind of a little stuck with family support.
You know, and one of the things that is true with the DDCAT tool, that they talk about training as being an important component, and we didn't get into that in this this session today. But when we're talking about peers, what are you folks suggesting, like sort of the minimal training for peers? Because we have a bifurcated system in the peer world too. We have mental health peers and we have the substance use disorder peers, and we're trying to do co-occurring care. What do you think would be some of the minimal practices that you would like to see a peer have going forward?
I guess I can say, I'll speak to that a little bit, is that, yeah, I think that is one of the things that we don't see a lot out there. And I think providers have it's hard to identify or hire peers who really have some co-occurring disorder expertise. Because as you said, David, they come from two separate worlds oftentimes, or at least, kind of credentialing around that. So, one of the things I know we've talked to with some programs is having them at least have like mental aid, or what is it? First aid, mental aid,
Mental health
training.
first aid.
Yeah, sorry. My dyslexia kicked in there. But so, just so that they understand the signs and the symptoms and kind of intervention. And so I think it's kind of like with all staff, some of that cross training probably becomes really important.
Mm-hmm.
I don't know if Matthew or Mike can speak to that question more.
I feel the same way, because do we have peers because we have two different trainings in Michigan where it's peer support, and then there are recovery coaches, and sometimes they'll have different certifications in terms of exactly what populations. I think, to me, recovery is recovery, no matter what we're kind of recovering from. But I think it is important to have that cross training, because people don't fit in those nice little cubby holes when we're looking at an assessment.
Okay, thank you.
Yep, which we haven't talked a lot about. We talked a little bit about in previous, but I think that cross training is so essential so that people really understand the different perspectives. Even sometimes mental health even in the same agency, mental health providers and SUD providers to really get together and talk about like what is their framework, where do they come from, so that they can understand each other, so thus the client can really receive that more whole person care.
A lot of education with the psychiatrists and the providers on that piece.
Yeah.
I appreciate that answer. And one of the people asked a question about what about coordination issues and in relationship to co-occurring disorders and co-occurring recovery? What are maybe like one or two important coordination items that people need to pay attention to going forward?
To me, I think it's education. I think when we're kind of going back to when I was talking about the drug courts and some of the CPS and some of the barriers, is I think a lot of times my role in that capacity was I'm advocating for the client. I'm not working for the court system. I'm not working on their behalf and developing that rapport, but also is the importance of, that education piece to the court systems, in terms of trauma, in terms of substance use, in terms of stages of change and recovery. I think that's where the coordination is to say that, I've worked with this client. Here are some things that I have identified that are barriers to this person being successful. And then with that coordination is then passing along those pieces for those experts to kind of be able to be in that full treatment team for them.
Michael, Dina, anything else?
Yeah, I was just going to say, it really, it speaks to that need for a high level of communication. I think many organizations are moving towards having coordinated care managers. And while I think that is a really important practice, it still is about, like, are you really making sure the information so that, the person doesn't have to explain their situation over and over again. But really high quality level of, exchanging of information between the various providers.
It's not passing the buck.
Yeah. What's that?
It's not passing the buck.
Yes.
In terms of, exactly. I'm done with them, they're yours now. It's how can we all as a community support them?
Yeah. You know, and I think the underutilized one area is really recovery checkups. And sometimes I go back to that. I was working on a research project, and we had a research interviewer, and she saw people, you know, at 6 months, at 12 months, at 18 months, and 3 years. And even though she wasn't a clinician, it was amazing how much clients really said, oh, like they were so grateful to see her. It really put them in a place where they're like, oh, wait a minute. Yeah, maybe like if they were no longer in recovery, it kind of prompted them to want to get back into services. So anyway, I think to be able to have that where people can stay connected is just key to that continuity of care.
So they got one more question coming in, and I realize that we got about 4 minutes. So I'd like to wrap up at least 2 minutes or so before we end here. But Noah from New York says, New York is embarking on listening sessions to explore combining mental health and addiction service agencies. How fundamental is that in successfully providing integrated care? We could go on for another hour.
Yeah. So I guess I'll take that since I'm the New Yorker on the call. So, you know, years ago, there were some discussions of our service. I mean, we're one of few states that have separate oversight agencies for mental health and substance use. The majority of states have merged systems of care, if you will. I mean, I think in theory, it should be hugely critical. I mean, the mistake we've made is we've siloed everything, which makes, you know, integration almost impossible. Really, the best we can hope for is coordination and collaboration rather than integration. And when you have competing service systems with competing demands and funding streams and, you know, requirements and all those sorts of things, you really can't get anywhere near the ideal around integrated care. So to me, you know, the systems, you know, have to merge unless they can facilitate integrated care in some other way. I know CCBHCs have been one avenue for that in New York State. I forget what that stands for. They're SAMHSA-funded initiatives on clinical care integration, but they've had fits trying to figure out who they work for. Is it mental health? Is it substance use? Is it SAMHSA? Is it someone else in the stratosphere? You know, whatever the case may be. So, I think it's a huge first step. But having said that, our neighbors in New Jersey merged 5 or 6 years ago, and really still most of the bumps continue to exist. So just because you merged, you can imagine that the lift in terms of, and the competition for, I mean, I think we addressed this years ago, and I think it was just, obviously there's trepidation around, well, if you're going to merge, is it really an even merge? Is someone coming in on top and someone's coming in on the bottom? And so it's going to be I think the merger is going to create more challenges initially, and then, you know, eventually in the long term, it will be a better thing for integrated care for New York State.
Wow. Thank you, Michael. And your colleagues there chimed in and said certified community behavioral health centers.
I could have figured it out if we had less than 2 minutes to go, but I decided not to. But thank you very much.
Great. And so let me start wrapping up. And I want to start with, you know, we've already done the question and answer, so we've been doing that. But I want to thank our guest today, Matthew Fox. Really appreciate you being here today. A big thank you to Michael and Dina and Meg, who's behind the scenes, and some other people, Jeannie, who's behind the scenes, have been working really hard to put on this 5-part series. So I'd like to kind of virtually give you all a really big handshake. Thank you, thank you, thank you. This has been a wonderful 5-part series. We have a survey for folks, and we'd love for you folks to participate in the survey. And that'll also come to you in an email following today's webinar. But if you want to take a second to fill it out today, we would love to have your comments. And with that, just to remind folks that you will automatically get a certificate for being here today. But if not, I put our email address in there, and send me the names of the people that participate in a group setting, and we'll make sure that that gets to you. And Did I miss anything? Dina, Michael, Matthew, any last things that I missed there?
No, thank you.
No, I don't think so, David. Just the one thing. I think you put in the chat box. All of these this series will be available for review and slides, and so just a reminder to people if they missed some of the other ones and are interested.
And with that, that reminded me, Dina, folks have, we built this slide set to act as a resource library for you. So it's not only the slides, but it's the links that are in there. So these are really rich, and we hope that you'll take advantage of them as they go along. They'll be posted there on the website for a considerable time, and the link you'll have at numerous occasions. So please make good use of those. And I think with that, we're seeing lots of thank yous in the chat box. I think we'll work towards closing. And again, thank you to our presenters and all the behind the scene folks, and all of you, the 290 people that were on here today. Thank you all very much. Okay.
Thank you,
Bye.
David.
Thank you.
Sure.
Yeah.
Yeah.